Hello, my name is Justin Oldham, Director of the Interstitial Lung Disease Program at the University of California, Davis. Thank you for joining me for this talk titled Early Recognition of Interstitial Lung Diseases. This presentation is made on behalf of Boehringer Ingelheim Pharmaceuticals Incorporated. The company has provided financial support for this program. Presentation content has been reviewed for consistency with the FDA guidelines. As we all know, interstitial lung diseases are a diverse group of conditions that can result in pulmonary fibrosis. This is a schematic of the interstitial lung diseases that we commonly see in our ILD programs. Idiopathic ILDs are probably the most common, with idiopathic pulmonary fibrosis being the most common of this group. We also see a fair amount of hypersensitivity pneumonitis, which can be related to mold, bacteria, animal protein, and chemical exposures. Autoimmune ILD, which can be caused by rheumatoid arthritis, scleroderma or systemic sclerosis, polymyositis and dermatomyositis, and less commonly lupus, mixed connective tissue disease, Sjogren's syndrome. And there's also a group called interstitial pneumonia with autoimmune features, which is a group that doesn't meet criteria for connective tissue disease, but has features of this disorder. They can also have variable degrees of inflammation and fibrosis on their imaging and pathology. Other groups that we see include sarcoidosis and less common ILDs, which we're not going to talk about today. Interstitial lung diseases are often characterized by exertional dyspnea and cough. These patients also develop variable degrees of fatigue. On pulmonary function tests, we often see restrictive patterns, and on chest imaging, we often see diffuse lung infiltration with variable degrees of inflammation and fibrosis depending on the underlying interstitial lung disease we're talking about. Many of these ILDs share overlapping symptoms, physiology, and radiographic patterns, making initial discrimination difficult for these ILDs. Signs and symptoms of interstitial lung disease can be mistaken for more common disorders. Unsurprisingly, there's a lot of overlapping symptomatology between pulmonary conditions such as pneumonia, emphysema, or COPD, along with asthma, and other conditions like heart failure and coronary artery disease. And for that reason, we often see misdiagnosis in these patients. Here on the right, we see a cartoon of normal lungs and what happens in interstitial lung disease. The terminal bronchiole ends in the air sacs called alveoli, with the venous and arterial circulation going to the alveoli. In interstitial lung disease, what happens is you get scarring of this alveoli that prevents oxygen from passing the blood and efficient carbon dioxide exchange as well. ILD misdiagnosis affects patient care as well as quality of life. In one study published by the Pulmonary Fibrosis Foundation, 55% of respondents had at least one misdiagnosis and 38% had two or more misdiagnoses. What's even more frustrating is that 75% of patients consulted 3 or more physicians before arriving at their ILD diagnosis. 34% had a delay of 2 years or more in diagnosis, which, as you can imagine, would be quite frustrating for patients. Most of these respondents noted that the diagnostic process negatively impacted their quality of life. Comprehensive history helps narrow the list of potential ILDs. I'm going to go through some of these that should be pursued in the primary care setting. First off is past medical history. Patients with interstitial lung disease variably report gastroesophageal reflux, a prior history of gastritis, cardiac disease including coronary artery disease, as well as type 2 diabetes mellitus. Current and past medications are important to elucidate in these patients. Chemotherapy and radiation therapy for cancer are well-known causes of pulmonary fibrosis, as is chronic use of amiodarone and nitrofurantoin. Exposure history is also important. Notably, tobacco exposure is a prime risk factor for idiopathic pulmonary fibrosis, which we'll discuss shortly. Drug use, occupations, environmental exposures, and hobbies or avocational exposures are also very important. Family history is critical in somebody for whom you are concerned for ILD. Family history greatly increases the likelihood of a family member having interstitial lung disease. The same is true of patients with sarcoidosis and autoimmune disease-related ILD. When assessing a patient with interstitial lung disease, a host of different sounds can be heard on auscultation. Patients with inhalational diseases often will have wheezes, squeaks, pops, and rhonchi, located primarily in the upper parts of the lungs, whereas those with more fibrotic predominant diseases will have fine bibasilar crackles. The timing and the location of the crackles can vary. They tend to be anticipatory, however, which helps distinguish them from other conditions like pulmonary edema due to heart failure. Consider ILD in any patient presenting with one of these features: a history of exertional dyspnea or non-productive cough, a patient who has a family history of interstitial lung disease or pulmonary fibrosis, physical exam and lab findings of exertional desaturation, lung crackles, or who have abnormal chest imaging either on X-ray or specifically high-resolution computed tomography. Also consider it in patients with abnormal spirometry, or if a full set of pulmonary function tests have been done, a low DLCO. Pulmonary function testing is critical in the workup of ILD. Let's discuss what we see on PFTs in these patients and others with pulmonary disease. Pulmonary function tests should be considered in any patient for whom you consider interstitial lung disease on the differential. PFTs allow the physician to evaluate lung function and better differentiate between obstructive and restrictive causes of lung disease, with interstitial lung disease being the primary cause of restrictive lung disease. In obstructive patterns, what we see is either a normal or decreased forced vital capacity. We see a decreased FEV1, we see a decreased ratio, and a decreased diffusion capacity. The opposite is often true in restrictive diseases, where we see a decreased FVC, a normal or sometimes increased FEV1, a normal or increased FEV1 and FVC ratio, and a decreased DLCO. Mixed diseases, which can be seen in sarcoidosis, cystic fibrosis, or sometimes combined pulmonary fibrosis and emphysema, which happens when you get COPD and ILD together, can cause variable degrees of each of these, with the notable exception of DLCO, which is almost always decreased. But you can see patients that have normal spirometry, normal volumes, but a markedly reduced DLCO. Laboratory workup to consider in patients for whom ILD may be considered include routine blood tests like a CBC, liver function tests, but it's important to note that most patients with ILD aren't going to have specific abnormalities on their lab tests. When a patient gets to us in an ILD program, we often will do various autoantibody testing, as autoimmune disease is a common cause of ILD. It includes an antinuclear antibody, rheumatoid factor, CCP, extractable nuclear antigens like an SSA, SSB, RNP, and topoisomerase or SCL70. You can get the ball rolling in the primary care setting by ordering these ahead of time if you do have a patient for whom ILD is either considered or confirmed. So high-res CT is the diagnostic test of choice in these patients. This should be considered over a chest x-ray if the patient has a high likelihood of ILD or you hear crackles on exam. X-rays can be nonspecific in their findings, can be poorly sensitive for early ILD, and this is a case of that. On the left panel there, we see an X-ray showing some subtle findings of fibrosis at the bases, but maybe one that would not be particularly notable to a radiologist unless the patient was symptomatic. Whereas if we had a high-res CT scan from the get-go, we would see that this patient has honeycombing, which would be quite concerning because honeycombing is one of the end products of fibrosis. In this case, it's a 43-year-old female who has 3 weeks of sinus congestion and cough with clear sputum, primarily after exercise. The X-ray being notable for some basilar scarring, but the CT scan showing pretty notable scarring that includes honeycomb cysts and certainly warrants attention from an ILD specialist. High-resolution CTs are critical for detecting pulmonary fibrosis and interstitial lung disease. What's important to note is that these should be non-contrast and contiguous 1 millimeter cuts. So if you're ordering a high-res CT in the primary care setting, it's important to talk to your radiologist to ensure that the right CT is done. If you do a contrast-enhanced study, you may miss some of the subtle changes of ILD because the vessels that are lit up by the contrast can be confused for reticulation. Similarly, if you're doing 5 millimeter cuts, you may miss some of the more subtle changes like honeycombing, and so it's important to have the 1 millimeter cuts. We also do prone scans sometimes. We also do inspiratory, expiratory if we're concerned about an inhalational interstitial lung disease like hypersensitivity pneumonitis. And so conveying the fact that a patient may have ILD to your chest radiologist is very important to get the right scan done. And in the right clinical context, high-res CT may be all that's needed. And so if you do the right test from the get-go, these patients may not need much workup afterwards. Lung biopsy is reserved for some patients, and it can add additional information for making an accurate diagnosis. Depending on the ILD that's being suspected, serologies and high-res CT may be sufficient, but lung biopsy is sometimes needed in other patients. There are various types of lung biopsies that are performed in these patients. Open lung biopsy is not performed regularly any longer. Video-assisted thoracoscopic surgery, or VATS, is by far the most common, and cryobiopsy has an increasing role in this patient population. But as you can imagine, anytime you do a surgery and remove part of somebody's lung, there is a risk-benefit ratio that needs to be weighed. And if the patient's too ill to undergo a surgical lung biopsy, you certainly don't want to increase their morbidity and mortality risk. Bronchoalveolar lavage, which is performed by pulmonologists, may provide some additional information, especially in patients who can't undergo lung biopsy and have a potential inflammatory interstitial lung disease like hypersensitivity pneumonitis. BAL can also rule out opportunistic infections and can be useful when the lymphocyte count is high, because this could indicate hypersensitivity pneumonitis or sarcoidosis. It is important to note that Unless one of those conditions are being considered, BAL is generally nonspecific and not particularly helpful in this condition. So now we're going to talk about a handful of different ILDs that can result in a progressive phenotype. These patients have variable degrees of progression, and when the progression occurs, they have reduced survival. And so we're going to talk primarily about idiopathic pulmonary fibrosis, hypersensitivity pneumonitis, autoimmune ILD, and we'll touch on a few others. So IPF is the quintessential progressive fibrosing ILD. The cause of it is unknown. It's probably the most common of the ILDs in general, and certainly the most common of the idiopathic ILDs. Hypersensitivity pneumonitis is a hypersensitive allergic reaction. And what's important in these patients is they're generally inhaling something, and so removing this inciting antigen is key. Autoimmune ILD results from immune-mediated damage to the lungs. Monitoring for ILD in these patients is critical upon diagnosis of an autoimmune condition. Unclassifiable ILD includes patients for whom a confident diagnosis cannot be made. And it's because even after a multidisciplinary evaluation at an ILD center of excellence, we still just can't give a confident diagnosis. And what's important also to note is these patients, while being the most common forms of progressive fibrosing ILD, are not the only patients that can develop this. And so if you have a patient with interstitial lung disease that's due to something other than these conditions, it's also important to acknowledge that they can develop progressive fibrosing ILD as well. In IPF, this is, like I said, the quintessential progressive fibrosing ILD. And so it's important to note that almost all of these patients will progress. So on to IPF, it's defined as a chronic progressive fibrosing interstitial lung disease or interstitial pneumonia of unknown cause. It has worse survival, as we see here, than many cancers, IPF being the third one down here. The 5-year survival is 30%. Compare that to breast cancer or colorectal cancer, about half of the survival in that group. Lung cancer still has worse survival than IPF, but not by much. IPF is rare in the younger population. The primary risk factors include being older male smokers. Patients are diagnosed after age 60. Most have some degree of smoking history. Most are former, however. And then male are more common than females. And so IPF should be considered in anybody with these risk factors, along with unexplained chronic exertional dyspnea, cough, and certainly anyone with bibasilar crackles on exam. Diagnosing IPF takes about 1 to 2 years. Unfortunately, most of the studies assessing how long it takes patients to be evaluated show that these patients wait considerable amounts of time and have considerable misdiagnosis before they reach a diagnosis. About 50% of patients are misdiagnosed initially, and that's because of the substantial overlap in symptoms between various pulmonary conditions, cardiac conditions, notably dyspnea exertion and chronic cough are not at all specific. And so patients are often misdiagnosed with more common illnesses such as COPD or asthma. This study here is looking at the time it takes to be referred to a center of excellence, and patients who were referred in less than a year had much better survival than those who waited longer to be referred. The reason for this difference isn't clear, but I will say at centers of excellence, we have extensive resources to provide patients, including pulmonary rehabilitation. We have respiratory therapists, social workers. We have nurses, pharmacists that can help them with their medications. We have clinical trials and lung transplant referrals that we can make. And so it's strongly recommended that anybody diagnosed with interstitial lung disease is referred to a center of excellence to ensure that they have access to these resources. High-resolution CT is essential for diagnosis of IPF. The high-res CT shown on the right here is a usual interstitial pneumonia pattern, which is characterized by basilar predominant subpleural reticulation with honeycombing. Honeycomb cysts are the small little thin-walled cysts seen primarily in the bases of the lungs here. You can also get traction bronchiectasis from the airways being pulled open by the surrounding fibrosis. When you have this usual interstitial pneumonia pattern, along with no other potential causes of the ILD, we make a diagnosis of idiopathic pulmonary fibrosis. If you don't have a usual interstitial pneumonia pattern seen here, at that point, we may need to consider a surgical lung biopsy. So it's important to note that crackles can be heard early in IPF. These are characterized by bilateral Velcro-like crackles that are heard mid to late inspiration, primarily in the bases of the lungs, progress apically as the disease progresses. When you do chest auscultation, it's very important to focus on the bases of the lungs and the mid-axillary lines, as this is where fibrosis primarily leads to crackles initially in the early stages of disease. And I will say that if you hear crackles on exam, they should never be ignored. Crackles can be caused by a handful of different conditions, but they all tend to be pretty important conditions if the crackles don't resolve on inspiration and clearing. And so if you hear crackles on exam, be sure to follow that up with high-resolution CT and even echocardiogram if they don't have evidence of ILD on the CT. What's frustrating about IPF is that the disease progression is quite heterogeneous. Some patients will follow this orange line along the top, which is a stable line. Most will actually follow the middle line here, which is light gray, where you're having a slow amount of progression every time you see the patient. And then the unlucky few will have rapid progression and die in the first 6 or 12 months after diagnosis. Complicating matters further is at any point along the way, you can have this dotted line, which represents an acute exacerbation. Those who acutely exacerbate often die, unfortunately. The mortality is about 82%. Even if you do survive the event, mortality is still quite high, only about 2.2 months of median survival after the event. So this is an example patient and key factors for considering IPF. This patient is 67 years old, has mid-late inspiratory crackles on exam, has clubbing, significant history of reflux, ex-smoker with a 20-pack year history, no drug use. The pulmonary function tests show a decreased vital capacity, a decreased ratio, decreased diffusion capacity, all of which is indicative of a restrictive pattern. The serologies are negative in this patient, indicating probably doesn't have autoimmune disease. Biopsy is not necessary because what we're seeing here on the right with the high-resolution CT is a basilar predominant process with subpleural reticulation and honeycombing. And when we see that, we call that a usual interstitial pneumonia pattern. And in the setting of no other probable cause of the ILD, we diagnose the patient with IPF. As I mentioned earlier, it's important for all patients who are willing and able to be referred to an ILD center of excellence so that the resources we have available to them are provided. So next, we're going to move on to hypersensitivity pneumonitis. So this is an interstitial lung disease that has variable degrees of inflammation that can result in fibrosis towards the end stage of the disease. So this involves the alveoli, the terminal bronchiole, and the interstitium. Inhaled antigens are generally what cause the disease, although we don't always know what antigen it is that causes it. It is mostly seen in patients that have frequent avian exposure by owning a bird or having down or having perhaps feather art in the home, or by mold exposure either inside the home or in the surrounding area. What we know is that secondary and prolonged inhalation of these substances basically sensitizes the patient and makes them become hyperresponsive. It's not a particularly common disease, only about 2 to 3 cases per 100,000 patients. And what we know is that identifying the causative antigen is quite important because it does impact survival, because if you remove the antigen, these patients can actually stabilize. So, as I mentioned, there's a various number of different conditions that can lead to hypersensitivity pneumonitis, including those who own birds, those who work in agriculture, various types of production, including cheese, various animal production, malt workers, gardening, and a whole lot of others. There is probably some genetic predisposition to developing hypersensitivity pneumonitis. There does seem to be some involvement of inflammatory genes, both with regard to genetic abnormalities and differential expression of these. Smoking is thought to be a risk factor for not having HP. Most patients with HP are not smokers, but I will say newer data suggests that this may not be as strong of a protective factor as initially thought. Symptoms do develop usually after a few years of exposure, and so patients with HP who present acutely can have a very acute looking form of the disease, whereas those who have more long-standing lower dose exposure can have this more fibrotic chronic HP looking picture. So here's our patient example with hypersensitivity pneumonitis. This is a 72-year-old, again, with mid to late inspiratory crackles and digital clubbing. This patient is a smoker, so as I mentioned, this is not protective for HP. Recently just developed a cough, and notable history includes working at a sugar mill, which can predispose to mold and various other types of dust exposure. PFTs also show a decreased vital capacity ratio and DLCO, indicative of restriction. Serologies show a positive HP panel, which measures specific immunoglobulins. And then the biopsy, while that's not necessarily needed, was consistent with UIP. And it's important to note that there is a histopathologic correlate of UIP that we see in patients with IPF, but other patients or other ILDs can also manifest in UIP. The high-res CT here looks quite different than what we saw in IPF. No longer are we looking at a lower lobe predominant process. We're now looking at an upper lobe predominant process with airway-centric involvement, still some subpleural reticulation. We're not seeing honeycombing here, but we are seeing ground glass opacities. All this makes this much more likely to be hypersensitivity pneumonitis. If we did expiratory imaging here, which is recommended for patients for whom HP is considered, you would see air trapping and mosaic attenuation, which is quite common in HP. If you have a patient with these sort of findings, again, it's recommended that they are referred to an ILD center of excellence. So next, we're going to move on to autoimmune ILD. So any of the autoimmune conditions can manifest in interstitial lung disease, most common being rheumatoid arthritis, systemic sclerosis, and myositis. This is a pretty exhaustive list of the various antibodies that can be tested in each of these conditions. I'm not going to go through these, but we do test for all of these upon referral to an ILD center of excellence. So these patients tend to have very variable degrees of overlap with the other conditions we've already talked about. They have crackles on auscultation. As opposed to these other patients, they often have positive serologies, which correspond to the autoimmune condition under consideration. They have diffuse lung involvement with variable degrees of inflammation and fibrosis, and they can manifest variable different patterns on their high-res CT, including nonspecific interstitial pneumonia, organizing pneumonia, or even a usual interstitial pneumonia pattern. It's important to note that interstitial lung disease is common in patients with autoimmune disease. So if you make a diagnosis of rheumatoid arthritis or systemic sclerosis, it's important to consider a high-res CT at the time of diagnosis for these patients because a good number of them will actually have ILD. And so if they have ILD at the time of diagnosis of their autoimmune disease, it's important to obtain the appropriate workup, including pulmonary function tests, doing a 6-minute walk test, assessing their dyspnea, and referring to an ILD center. If they don't have ILD on their initial high-res CT, it's important to monitor their PFTs with some regularity, probably every 6 to 12 months, to ensure that their vital capacity and DLCO remain stable. If you see the vital capacity or DLCO start to drop, at that point it may be indicative of developing ILD and you want to consider repeat imaging. So here's our patient example. We have 2 patients here. This one is a 40-year-old female. You'll notice autoimmune disease tends to be younger patients than what we were seeing with IPF and hypersensitivity pneumonitis. Also female predominant disease as opposed to IPF. This patient has not only shortness of breath, but also has Raynaud's phenomenon, has similar looking PFTs as we've seen before. This patient has a positive SCL70 antibody, which goes along with systemic sclerosis. Biopsy is not needed, nor should it be performed in patients with autoimmune ILD because it's not going to change the management generally. When we look at the imaging here, we see ground glass opacities in a basilar predominant pattern, also a little bit of subpleural sparing and traction bronchiectasis. We would call this pattern nonspecific interstitial pneumonia and make a diagnosis most likely of systemic sclerosis. It's important to involve your rheumatologist, obviously, because this disease process requires not just input from a pulmonologist, but also a rheumatologist. Next patient we're going to look at is also autoimmune ILD, older male smoker. So you may be thinking IPF just based on the risk factors here, has very similar looking PFTs, has a pretty similar looking CT scan, although rather than just having a UIP pattern, we're now seeing some ground glass opacities as well, which indicates some inflammation. Patient has a positive rheumatoid factor, and again, a biopsy is not necessarily taken, but if the patient has joint symptoms that are consistent with rheumatoid arthritis, and again, getting a rheumatologist involved is important, you would make a diagnosis of rheumatoid arthritis-associated ILD, and again, consider referring the patient to a center of excellence. Finally, we're going to talk about unclassifiable ILD. Again, these patients are those for whom a diagnosis can't be made after an exhaustive workup. We do recommend these patients be seen at a center of excellence just so that they can be put through the multidisciplinary discussion, which we'll talk about. And so the causes of somebody to be unclassifiable include discordant or overlapping histologic findings, discordant findings between the clinical, radiologic, or pathologic features, significant overlapping features that preclude a firm diagnosis. The way we determine whether a patient has unclassifiable ILD is using this algorithm here, which asks whether we have high confidence in the diagnosis, over 90%. If so, we make a confident diagnosis of that particular ILD. If we can't make it with high confidence, then we ask, is there a leading diagnosis that has over 50% confidence? If we have a high confidence, then we make a provisional high confidence diagnosis. If it's lower confidence, then we call it a low confidence provisional diagnosis. In patients who have no confidence in our diagnosis, those are the ones we label unclassifiable ILD. These patients unfortunately do have a fairly poor prognosis. 2-year survival is only about 75%. 5-year survival is 40 to 70%, which is not as bad as IPF, but not as high as autoimmune ILDs. Chronic fibrosing interstitial lung disease with a progressive phenotype is characterized by ILDs with variable degrees of inflammation and fibrosis, but with uniform disease progression. There are various different signs of disease worsening, including physician or patient impression that the disease is worsened, declining lung function tests, worsening symptoms, decrease in the exercise capacity, acute exacerbations of the disease, and increasing fibrosis on CT. Again, when the lung damage occurs, pulmonary fibrosis results from aberrant wound healing. And so irrespective of whether there's preceding inflammation, fibrosis does tend to be the end product. And so while many different ILDs can manifest differently initially, fibrosis does tend to be the end product regardless of the initial cause or insult. Recognizing ILD is critical to proper patient management. An accurate diagnosis allows the physician to provide patients with appropriate prognostic information and develop an appropriate management strategy. It is important to note that as fibrosis progresses, patients will become more breathless, less mobile, and less independent. And so making that clear to them is important so they have appropriate expectations. One resource we provide at Centers of Excellence is a multidisciplinary discussion. This is where we get pulmonologists, radiologists, pathologists, and sometimes rheumatologists in the same room together. We present our cases from the prior week or two, and we come to a consensus diagnosis. This approach has been shown to increase diagnostic confidence and allows us to move forward with an appropriate treatment plan. Thank you for joining me today. For more information on this topic, please visit insightsinILD.com, and here's a QR code to get you to that website.